You only have to examine the bone that I'm giving you. You don't have to examine all of them. Okay.
Let's do it again. The problem's on the left foot. You look at the left foot first.
Did I say that?
Yeah. Yes.
I'm really not. I really need some sleep. It's your fault. If the problem's on the left foot, see, I'm looking at this as her left, and it is. We'll do this tomorrow. Okay. The problem is on the right foot. This is right?
Yeah.
Put an R on here or something for me. The problem's on the right foot. You got to examine the left foot first, and you have to do it correctly. Do it the way I'm showing you. So, if I was examining that foot, I would be kneeling on my right knee. Okay, the knee that is closest to the patient, I want you to have examining your patient. Okay. If I tell you that you're going to adjust the navicular, the only thing you have to examine is the navicular by stabilizing the talus, moving it I to S, S to I, right? And that's the only thing I'll have you do. And then you'll tell me if it's dropped inferior and gone medial, the restriction is going to be with the I to S glide, some medial to lateral. Okay? So remember that. Okay, so the motion palpation for the talus, we're going to just feel it slide under the mortise joint and come back out from underneath the mortise joint as you're putting the patient's foot through full dorsi and full plantar flexion. Okay? You may also add somewhat eversion or inversion, because when the talus moves anterior, sometimes it'll have a tendency to move a little medial or a little lateral. Remember, when you're examining your patient, you always thrust through the restriction. So if it's not dropping back this way, then I know that I'm going to have to thrust it back in that direction. Okay, so if it's anterior medial, I'm going to thrust it from medial towards the posterior. Right? So that's your motion palpation here. Again, of the navicular, it's like this. To go down and do the first cuneiform, it's just like this. Right? You're comparing it up to the navicular. Or I don't care if you like horse collar the navicular while you're motioning the first cuneiform. Okay. Then the second one, you're going to come down the second metatarsal until you get to the second cuneiform, and you're going to move it up and down. Then you're going to go down the third one to get to the third cuneiform, move it up and down. Okay. Everybody got that? Okay. If you're going to motion palpate this fifth metatarsal head, this proximal one, I want you to stabilize in here like this, grab it, and move it up and down. Okay. I'm stabilizing the cuboid while I'm moving this in this fashion. Okay. This will generally move up and out. To motion palpate the cuboid, you're going to come in and stabilize the calcaneus. You're going to grab a hold of this, which, remember, just fall into this indentation just proximal to the fifth metatarsal, and you're going to be moving it up. The calcaneus, you're going to stabilize the talus as well as you can, and you're going to do like a figure 8 type movement right here. If it's gone anterior, it's not going to go posterior. If it's gone anterior medial, it won't go posterior lateral, etc. Okay? Everybody got all that? To motion palpate the distal metatarsal heads, it's this way, just like this, going through all these. And the idea of what you're doing is you're pushing the distal metatarsal head up, not the proximal portion of the phalange. Okay? Seeing if there's any motion. Again, always comparing the good side first, and then examining the bad side. Okay? Alrighty. Is there anything I missed on that as far as the motion palpation? Don't think so. Okay, I'm going to have you just sit and face me, let your ankle hang off here a little bit.
Dr. Fehl, are you going to ask us ankle sprain on Friday?
Am I going to ask you what?
An ankle sprain.
Oh, yes, thank you. Inversion sprain, thank you. That's one we're missing. If someone has an inversion sprain, they roll their ankle out. The best way I know to examine that is to just take this like this. Grab it just like this. Put your thumb down over the swollen part, which is probably going to be in the subtalar joint here. Holding onto the calcaneus on this side, getting a little bit of influence in here on the talus on the top here, and just motioning it this way. And you'll sometimes do it a little more just straight lateral or straight eversion. Sometimes you'll do it with more dorsiflexion with eversion, but that's what you're doing. You're not going to put it more into inversion, remember that. Okay, and while we're here, we might as well just go over this adjustment. It's the same thing. You're holding it the same way. Depending on where the restriction is, you'll thrust through it. You'll take the traction, and you'll turn it back up under. Just like that. Okay, and you can do that, of course, over here, stabilizing the distal part of the patient's leg here, taking out your slack, and thrusting this way. Okay? You're thrusting it up and underneath because it's rolled out from underneath this mortise joint, underneath the subtalar joint, we're putting it back up under. Okay? If we're going to adjust the talus, chiropractic index finger right over top of the dome of the talus, take out your slack and do it with a scooping action as you're tractioning it and setting it down. If it's gone anterior and lateral, then you're going to add some eversion to that while you're doing it and a little bit of lateral to medial in your thrust, trashing it and thrusting it again with a scooping motion, but you're going to add lateral to medial in that. If it's gone anterior and medial, you'll do it the exact opposite, other hand. This time I'm going to add some inversion to the foot, take out the slack, and thrust it back under. Okay? Can you all see?
Yes.
Okay. Next thing we're going to do, we're going to talk about the navicular. Make sure you know your landmarks. Here's the navicular tubercle. The navicular is probably going to drop more inferior, and that's what I'm going to test. I showed you how to do all the superior ones, but I'm going to be testing on the inferior ones. Come up underneath with your phenon. Stabilize the top of the patient's foot with the volar surface of your hand, just like this. Take out the, I want you to plantar flex, and I want you to invert, and you're going to thrust it up. Like that. That was free. And then we can move up, do the same type of movement if you like for the first cuneiform. Set it this way, set it up. Okay? Doing every one of these distal metatarsal heads, remember you're going to contact, you're going to traction, and you're going to have this part of your finger, that middle phalanx coming right up underneath the distal metatarsal head, not the proximal phalange, the distal metatarsal head, and shove it up. Shove it up, right? You can also do this first one like this, which is fine by me, bringing your thenar up underneath here, stabilizing it with your thenar of your other hand and thrusting it up and over this way. Okay. This way. Okay. This fifth metatarsal head, you can just stay. I'm going to have you just move up on the table, but you don't have to bend your knee. We talked about this the other day, remember? It might be easier on you if you just don't even bother bending the patient's knee. Keeping their leg in this position might be more comfortable. Just make sure you're getting your line of drive to go S to I relative to the top of the foot to the bottom of the foot, which would also be considered anatomically from A to P. So coming down on top of this, leaning forward, adding some dorsiflexion and some eversion, and thrusting it down. To do the cuboid, it's going to look very, very similar to the way you did the navicular on the other side, except that I'm doing some stabilization here, as you can see, on my navicular with my fingers as they wrap around here. And you can see my forearm is just about in line with her tibia here, right? I'm not coming from over here. I'm thrusting it back up. There's a little bit of lateral to medial. But if you're over here like this, you're not doing it right. Okay? Come up here, add plantar flexion, eversion, and thrust it back up to where it needs to go. Okay? The calcaneus will go anterior medial, anterior lateral. You're going to want to get it a little bit off the table this way. I showed you the contact points. Before we leave, make sure you look at Charlie. Make sure you know exactly where you are. And when you show me your contact points, you're just going to point to them. Okay, so it's going to go like this here. If it's gone anterior medial, get as much stabilization into the talus as you can, the distal tip, fib, and contact, and thrust it back under this way. Because if it's come forward and out, we have to close the joint on the outside of the foot, thrusting it under. If it's gone lateral, it's the exact opposite. Stabilizing. You can see this hand is on top here, taking the bone, shoving it back under. Okay? You can stop me at any time. Any questions? Okay, let me have you lay prone. A couple of different bones we adjust, the cuneiforms and also the calcaneus. Generally, the way to scoot up just a wee little bit more. There you go. You want to make sure you have the distal tib and fib stabilized on the table. If you're adjusting the person's right, I suggest you use your right hand, come up underneath the, get as much stabilization into that talus as you can. And remember, you're just on the straight posterior part. If it's just come straight posterior, you're going to shove it straight posterior. Okay, you're not cocking it like this. That's not the adjustment. It's straight down. And if the joint is open medially, that means it's rocked this way. So when we thrust, we're going to torque it back over. If it's open over here, we're going to torque it this way. Right? Yeah.
The motion palpate, is that the one that you...
That's the figure 8. When the patient is seated.
That's when you stabilize the talus and you just move the calcaneus?
Yes. Okay. Also, you can adjust the first, second, or third cuneiform this way. So all you do is if it's gone, if it's dropped, you have to find where you need to be. You're going to find your navicular tubercle. Just distal to that, you're going to run into the cuneiform. So here's your first one, here's your second one, here, and here's your third one. Second one would be way up in there, third one's a little easier to get to. Look at them on Charlie, you'll see. The way I want you to make the adjustment, I don't care which one of these you adjust. Of course, it depends on what I tell you, but I want you to put a thumb on thumb contact, thumb on thumb. I want you to spread the bones like I'm doing right here, and that'll give some room for that. Now, it's not a whipping action like this. I'm not whipping her foot at all, and you want to control it. You don't want the patient. In fact, all these adjustments, you have to look at all the muscles around the extremity you're adjusting. It has to be totally limp. You're going to push it back to its normal position, which would be to the right. That would be through the restriction. So if it's to the left, you're going to have a left to right restriction, so you have to get it over there, and you have to do it in some intelligent fashion, right? So you don't ever want to hurt your patient, but just because you may have not read about it in a book doesn't mean that your concepts or ideas are not better than what's already out there. Right? But you have to be intelligent. You have to explain to your patient what you're doing. You have to use informed consent, etc. So there's all kinds of ways of doing it, except on this test. Right? If you don't motion pop, I'm going to tell you if you do everything right, but except the way I told you, points off. So practice, grab a patient. And if you have any questions, ask.